Sawadika Jan, I'm very, very pleased to be here today with you. Thank you very much for the opportunity. And I would like to take a moment to remember all the people who have died from tuberculosis this year. Many more people have died from tuberculosis this year and in the last year than was the case before. And many more people have died compared to the number that needs to die. So I would just like to start by saying that in the last 2 years, we have seen a massive decline in TB case notifications in the year 2020 as well as year 2021. And if you look at the 6 WHO regions, you know, WHO works in different regions. We have Afro, we have the Southeast Asia region, where we are today in Thailand is included in that. We have Wipro, we have PAHO, we have Euro, and pretty much in 4 of these, we are seeing a huge decline in case notification. Now, you could say, you know, case notification could be that there are fewer cases. You could say case notification is coming from, you know, less reporting. But today I'm going to make the case that this decline in case notification is really coming because we in the health system have not been able to support the TB response while the COVID pandemic has hit us and continues to hit us in many parts of Asia and Europe. So while we're talking about TB more broadly, I am putting forward for you a very, very detailed, minute graph of all countries that have high MDR TB burdens. And you will see here that even in countries with good health systems, I'm talking about places like China, we have seen that many people who would have been treated for MDR TB have actually not been treated during the COVID pandemic. So again, a lot of cases were detected, but the people who were put on treatment, there continued to be a big gap. And this gap has always existed, but during the COVID pandemic, it has become worse. And I want to talk a little bit about preventive TB treatment. Now, as you all know, about 1/3 of us are living with the TB bacteria. We are infected with TB, but we may not have progressed to disease. We cannot treat our way out of the TB pandemic by simply focusing on TB patients. We have to focus on infection. And in 2018, there was the UN High-Level General Assembly meeting where for the first time, there was a global target set for ending TB, which included TB preventive therapy treatment. And that number was very modest. We said that 30 million people needed to be treated between 2018 and 2022 with TB preventive therapy. And as you know, TB preventive therapy is for people living with HIV, contacts under the age of 5. And now we are looking also at contacts aged 5 and over. Mostly we are thinking here about household contacts. So you can see that till 2018, the figure was really, really very small. We were doing TB preventive therapy for 1 to 1.5 million people. And when this UN General Assembly declaration came out, countries really made a huge effort to say that we must do more preventive therapy. And in 1 year, the figure nearly doubled. We were treating you know, existing drugs and the new drugs, that is the rifampicin, the shorter regimens that we call 3-HP, 1-HP, were still not fully available. But with the existing drugs, countries started doing a lot of TB preventive therapy. And that has also begun to crash in 2020. And when you see 2021 data, you will see that, again, this number has come down to the levels of 2017. Who knows, it could even be lower than that. So clear impact on case notification, clear impact on the number of people who were detected but were not put on treatment, and a very clear impact on TB prevention. Now, it is important to say that there have been regional variations when we look at the data that I just showed you. And this is really to do with four important things. The first is, when were countries first affected by the COVID-19 pandemic? So, not all countries were affected at the same time. Countries such as Thailand had a relatively late impact because the system was able to cope quite well with the initial levels of infection. But recently we've seen that there have been significant challenges. So you can see that countries were hitting the pandemic was hitting the countries at different levels. But then there was also the severity of the impact. Many of you may have heard stories of what happened in India. I'm located in India. And last year, particularly in the period between April and June, we were really not coping. We had a very, very severe pandemic, which was leading to a lot of morbidity, a lot of mortality, and the system was not able to cope with that. The other important part has been what has been the extent of restrictions that were put in place to address the pandemic. Again, countries have had a different view on this. Countries like Sweden, as you may have heard, or countries like the UK have put in very different restrictions to some of the countries in our region. And so that has also impacted not just the supply of healthcare, but the demand for healthcare. And finally, the most important factor has been, what is the capacity of the health system? What is the resilience of the health system to cope with the COVID pandemic and continue to deliver essential health services? And this is something which, again, varies a lot. Needless to say, countries that have developing health systems, countries that have very few health staff, we know that there is a huge shortage of health staff in many countries, have really struggled to be resilient and to be able to provide essential healthcare services in the face of the COVID pandemic. Now, let's talk a little bit about our region, the region that we live in. So what I've got here is a pie chart, which is showing you where TB globally actually sits. Where does the burden for incident TB sit? And as you can see, if you exclude the European and the American region and the Eastern Mediterranean region, really most of the TB is sitting in Asia. Africa has 25%, but if you total up the Western Pacific region and the Southeast Asia region, we are looking at about 60% of the global TB burden, incident burden. But if you were to talk about mortality, where does TB mortality sit? Then more than half of all of TB mortality sits in the WHO Southeast Asia region. And this is the 11 countries in the 6 countries from Southeast Asia, and then Thailand, Myanmar, Indonesia, Timor-Leste, DPRK are the other 5 countries. So 6 of the highest TB burden countries globally sit with us. And if you only looked at Indonesia and India, they collectively make up of 1/3 of the global TB incident case burden. So as a region, we were hit very hard, not just by the TB pandemic, but also by the COVID pandemic. So this is just showing you what has been happening to the case notification. I think I mentioned this to you earlier. We had a very slow decline. Our incidence was coming down very slowly. But then, of course, we began to see the decline in case notification. And this is what is happening to the decline in deaths. Till 2018, we were beginning to see a decline in deaths. And now this is going up, and we are now at the level of mortality that we were in 2015. So we have lost 7 years of progress. In the last 7 years, we are back to the level at which we were at in 2015. Now, let's just take a step, to look at where were we before the COVID pandemic hit. So a lot of what we say today about the TB epidemic is related to COVID. But I'm going to make the case that even before the pandemic hit, we were not doing well in TB. TB continued to be really ignored. The political commitment for ending TB has improved, but frankly, the uptake of technology, available technology, has been very, very limited. The uptake of treatment and the uptake of social protection for addressing catastrophic costs has been really, really limited. So we've seen only an 11% incident TB decline between 2015 and 2020. The number of TB deaths, as I was saying, between 2015 and 2020 has only declined by 0.2%. And the percent of people who are suffering from catastrophic costs, this should be zero. The target in 2020 was zero. If I combine the data that is available from 4 countries in our region, it continues to be 43%. But if you were to see what that is in Timor-Leste, it's 83%. If you were to look at what it is in Myanmar, it is over 63%. Even in Thailand, with a wonderful health system, MDR TB patients are facing, 30% of them are facing catastrophic costs. And to just remind ourselves that catastrophic costs are when people are having to put more than 10% of their combined household resources towards TB treatment. Children are not going to school because of TB. People are selling their homes because of TB. And that is unacceptable in today's day and age. Now, I just also want to look at what is happening to preventive therapy. Remember that in our region, we are supposed to go to 11 million. So out of the 30 million globally, our target in our region was 11 million, and we have reached 1.7 million. Basically, if you look at the people who are eligible for preventive therapy in our region, and I'm talking about people living with HIV, children under the age of 5, we are not doing the most basic preventive therapy work in TB. And this was the case even before the COVID pandemic hit. In our region, in SEER, in 2021, 700,000 people have died of TB. And this is 100,000 more people that died in 2019. And of course, we think that this is because of a multitude of COVID-19 related reasons, which included limited access, limited demand for TB diagnosis, a lack of availability of treatment and support. For example, I will give you the example of India. In India, we diverted 1,500 gene expert and mole bio machines that are normally used by the TB program to diagnose COVID. We diverted the health staff, including WHO consultants who would normally have worked on TB to work on COVID. So the entire health system took away resources from other programs to be able to respond to COVID. And while capacity has developed significantly in the last 10 months or the last year for COVID diagnosis, we are seeing that we've still not recovered in the TB program to the levels of diagnosis, to the levels of treatment that we had in 2019. So this is the global shortfall in TB case notifications. Which countries are contributing the most to it? You can see that the biggest contributor is India, followed by Indonesia, followed by Philippines, followed by China. We also have big contributions coming from Bangladesh, from Pakistan, Myanmar. And then the countries in Africa, the Ukraine, etc., the Russian Federation, there is some shortfall, but really it's coming from 4 big countries in Asia, from 6 big countries in Asia. So this is where the battle for TB and COVID is going to be won or lost. Now, I talked about what was happening in 2019. Let's take a look at what happened in 2021. So I went to the Indian online data portal for TB, where data is now reported every month. So we have pretty much real-time data available for TB. And what you can see is that we had a huge crash in April, May last year. And even today, we continue to report less than 200,000 cases, cases notified. To put it into perspective, India has 2.7 million TB cases. So you can see that there's really very, very little happening in terms of notification when we are hit by a big wave, and continues to be the case till February this year. Now, this is data from Indonesia, and what you have at the top is the green dotted line, which shows you what were the number of cases notified per month of new and relapsed TB cases. And then you have data for 2021 in the blue line, and data for 2021 in the green line, data for 2020 in the blue line. And you can see that we are nowhere close to reaching 2019 levels. And you can again see that the peaks and troughs are related to, the particular wave of the COVID pandemic. But the bigger point is that we are still not back to the levels that we were in 2019. Now, so far I've talked about what happens to the TB cases where disease is happening or where infection already exists. But we don't know how the COVID-19 pandemic will impact undernutrition. 23 crore people in India. So let me see how we put that. 23 crore will be nearly 200 million people have been pushed into poverty. And that is probably happening in several countries. People are being pushed into poverty. Now, if you look at the determinants of tuberculosis in our region, one of the biggest determinants of tuberculosis in our region is undernutrition. We have about 30 to 33% of all incident TB cases in India, in Timor-Leste, in Myanmar, are coming from undernutrition. So how is additional hunger, additional undernutrition going to impact the COVID-19 pandemic? This is something that we have to see, because this is not something we will see today and tomorrow in the number of cases. You will likely see this over the next 4 to 5 years. We also have significant economic impact. Countries have contracting GDP. We have job losses. How does that loss of social protection also impact the the TB pandemic? Will more people start drinking alcohol? Will there be more smoking? We will be watching to see what happens to this. On the other hand, you have some improvements in infection prevention. You have some social distancing, you have mask wearing. Now, in the short term, the mask wearing will protect to some extent against transmission of TB as well. But as countries begin to release policies where mask wearing is no longer mandatory, and it's not possible for people to keep wearing a mask all the time. We live in a very hot region. It's not easy to wear a mask all the time. So how will the impact of masks show up in infections is also something that we will be looking at. And the TB community doesn't really know how to factor this in, so experts are talking to try and understand how these impacts will actually show up in different ways, and they may show up in different ways in different countries. Now, we tried to do some modeling we worked with Imperial College, that is us in the WHO team, to see what is actually likely to happen. So we looked at the data that was coming in from countries, and we worked with our 11 countries, and we started looking at the possibility of incident infections per month. What would happen to that? And we had some assumptions. We said that there would be no additional interventions. So this is a situation if you do nothing additionally, you continue to run TB programs as the way they were being run. We assumed at that time that there was a total period of 4 months of disruption, but in fact, as you can see, there has been almost, much more disruption. And we assumed at that time that, there would be restoration to pre-COVID times within 5 to 6 months. And we also assumed that there would be reduction in TB transmission during the social distancing period. So when we looked at this, what we saw was we would get an initial, in the first year or so, a decline in incidence. But then incidence would go up and it would peak between the second and third year and then begin to decline again by the end of 5 years. But what was interesting for us was that even after 5 years, we were not at the level that we would have been if TB had continued to decline slowly in our region at about 2%, per year. So that was really quite worrying when we saw this. And of course, the basic problem right now is that the effect of COVID-19 is ongoing. Countries continue to witness late surges. We are seeing second, third, fourth, fifth waves, and there is a staggered impact. And of course, as I mentioned earlier, preventive therapy has taken a really big hit. And we are not being able to bring in people who are not actually sick. The health system is prioritizing people who are sick. They're not going to focus their resources on people who are not sick right now. So this is really, what we've been able to understand from trying to model the impact of COVID in our region over the next 5 years. Now, the other thing to understand is that due to disruptions, due to the limited capacity of the health system and the limited demand for TB treatment, we are going to end up with a large pool of prevalent cases. And this prevalent pool, because it's going to be large, is going to continue to generate infections. That is partly the reason for the increases in the incidence. And that is where we can impact most. We still don't know what is going to happen to undernutrition, et cetera, but we know where the prevalent pool is. A lot of people have been diagnosed but not treated. And we really need to focus on reducing that prevalent pool to the smallest level possible to reduce the impact on incidence. So I'm going to wind up now. I'm coming up to 20 minutes. So what are the key messages that I'd like to share with you? I think really what I'm trying to say is that there is a huge intersection between poverty and socio-developmental challenges in our region that we've always known. It's a poor region. There is a lot of undernutrition. There's a lot of diabetes. And now, what is the impact of COVID going to be on some of these social determinants? What is the impact of COVID going to be on comorbidities? We are still looking at that. What is the impact going to be of better infection prevention control? We are still looking at that. But what is clear is that we've seen a sharp decline in the diagnosis of TB, in treatment of TB, and in preventive therapy of TB. And this is translated into more people dying. And 100,000 more people died in our region additionally to what is already happening. But remember that TB is an imminently curable disease. We should not be seeing case fatality of more than 5%, given that we have all of the tools available to address it. But we continue to see in countries case fatality ratios of 17%, 20%. Why does that happen? Because of delayed diagnosis, because of inappropriate treatment, because of not being able to identify drug resistance in a timely way, people continuing to push empirical treatment. And I have been amazed to see the scale up of gene expert in our region. You know, countries have gone from having no gene expert to having 150, 150, 1,500, et cetera, et cetera. But when I go and I look at utilization, 17%, 20%, less than a third of all cases that are diagnosed in our region are diagnosed with a rapid molecular test. So, it doesn't have to be gene expert. It can be any rapid molecular test. And the issue there has continued to be people feeling that the cost of diagnosis continues to be prohibitive. I know that in some countries we are paying between $20 and $30 for a gene expert test, even though the price that has been agreed internationally is $11 plus procurement. But even that price for some countries is problematic. And we continue to hear stories about, we don't have cartridges or the cartridges have expired because people are not using it because they're worried that it's too expensive. So we end up with cartridges being expired and expert machines not being maintained. So it's not just a question of supply of products. Developing new products is really, really important. But at the same time, the use of those products is something that we don't pay enough attention to. The introduction of those products, the utilization, the funding and maintenance is something that we really do need to be doing much better at. Second point I want to make is that even before the COVID pandemic, the progress on TB was not sufficient to meet either the SDG goals or the UN high-level goals that were set in 2018. So there is an urgent need to renew the response to TB, and it cannot be the medicalized approach that we had several years ago. What is very clear is we have to address the social determinants of TB. The social protection aspect is going to be really important. And TB cannot be addressed just by the health system. It needs to be multi-sectoral, the Ministry of Finance, the Ministry of Labor, the Ministry of Justice, where all the prisoners sit. This is where we need to really be coming together and making sure that the response to end TB is not just passed off to NTP managers, to TB programs to say, oh, this is your job. The response cannot be passive that, somebody will come to a tertiary health facility, because by the time they come to us in health facilities, it is too late. And we have seen again in prevalence survey after prevalence survey that up to a third of TB cases who have significant TB, have significant cavities, are actually showing atypical symptoms of TB. So we cannot be saying, oh, you need to have a cough for 3 weeks and you need to be sweating at night and you need to have weight loss, and then we will think about TB. We should be thinking about TB first. So we need a much more broader definition for who has access to diagnosis. And we really do need to be phasing out smear microscopy completely, except the use of that for monitoring TB. We should not be using it at all for TB diagnosis. Now, all of this needs funding, and there is a huge funding gap. Globally, there is the need for 13 billion to end the TB pandemic per year. In our region, and I'm just talking about the 11 countries in Southeast Asia, the amount is 3 billion that we need. We have available currently 1.4 billion. Funding for research, really very, very limited. We need much more money for research. The TB vaccines, some very, very interesting work happening right now around TB vaccines, including, a repurposed BCG vaccine, the M72 vaccine that the Gates Foundation is working on, which is to address, people with disease already. We need money to make sure that research for TB vaccine is fully completed. It can be introduced. Otherwise, the dream to end TB without TB vaccine is really not going to happen. So overall, my key message is funding is critical, and we cannot keep waiting for donors to say, please, Global Fund, give us more money. Please, USAID, give us more money. The money has to come from domestic sources. If you remember that most of the TB is sitting in countries that are no longer considered low-income countries. They are middle-income countries. So people will be phasing out, the donors will be phasing out, and the $20-30 million that we get per year in some countries is important, but not going to be enough to end the TB pandemic. So we need new funding instruments. We need clarity on how more money is available, not just at the national level, but at the local level, at the subnational level, because many of our health systems are decentralized. So we need to be making sure that funding is available at the province level, at the prefecture level, at the local level to address TB, and the health resources that we need, the people that we need to be able to generate demand. And I'm talking about community providers here, but also making sure that TB is decentralized within the health system. Nurse-led models are going to become really important. The role of the pharmacist is going to become really important in addressing adherence. We cannot keep TB at the level of a tertiary health facility. Primary healthcare has to do much more for TB, and we need to be making sure that as we move towards point of care diagnostics, where TB is going to be diagnosed at the point of care, we cannot expect people to then travel to a provincial level MDR facility. People have to be treated where they are. We cannot put people who have TB to transport themselves on public transport. If you have MDR TB, to go 100 miles to the nearest MDR facility. Treatment needs to be decentralized. So I'll stop here, and I would like to thank you very much for your time and inviting me to this. Let us pledge today that all of us will go back and advocate strongly for more funding for TB and for decentralizing TB, and to make sure that while the COVID pandemic continues to hit us, we do not forget about people who have died unnecessarily from TB this year. Thank you very much.